I'll introduce our final speaker. This is Dr. Kimutai Katwa. He's an early career psychiatrist based in Nandi County, holding a Master's of Medicine in Psychiatry from Moi University, where he also served as the chief registrar. His clinical and academic profile is well-rounded. It encompasses active community psychiatric engagements, research experience with NeuroGap, where he was a research assistant, and a thesis which looked at relationship between schizophrenia, bipolar mood disorder, and alcohol use. So Dr. Katwa brings a notable international exposure. He's undertaken external rotations with Brown University affiliated hospitals, covering child psychiatry, adults, addiction, and geriatric psychiatry and neurology. Most recently, he represented Kenyan psychiatrists at a neurology course in Namibia. So let's welcome Dr. Katwa to take us through his presentation.
Okay, thank you all. And thank you, Chiromo Hospital Group, for considering my submission. And thank you for inviting me to present it. So today I'm going to present about the bridge between the various fields that treat the brain of a human being. I think Prof. Atwoli had talked about it earlier. So recently I went to Namibia and I went through a course that trained us on various neurostimulation interventional techniques to manage brain disorders when biological interventions fail us. So my name is Dr. Katwa and I'm a psychiatrist. I work for Nandi County. So the background. So last year in November, I was invited to Namibia by European Academy of Neurology and African Academy of Neurology to undertake a training. It is called RTC that was conducted in November. And during that training, we were taught about various cutting-edge interventional techniques for management of psychiatric and neurological disorders. So the focus of the training was it emphasized on the multidisciplinary approach to brain disorders. That was the approach that encompassed neurology, neurosurgery, and psychiatry. And it also covered neurodegenerative disorders that have already been covered by the previous speakers. And that is Alzheimer's disease, Parkinson's disease, and other types of dementias. Also seizure diseases, and also psychogenic non-epileptic seizures and functional neurological disorder. So it also covered emerging therapies most relevant to psychiatry, and that was deep brain stimulation, responsive neurostimulation or RNS, and vagus nerve stimulation or VNS. This being the latest techniques used for neurostimulation therapies that are going to replace ECT. We all know the weaknesses that ECT has. So these therapies are newer and are emerging to replace ECT, which we are more familiar with. So we are not going to discuss it today. So the three key modalities were, as I mentioned before, DBS, RNS, and VNS. So these neurostimulation therapies represent a major advancement in the management of neurological and psychiatric disorders. And these therapies modulate the abnormal neuronal activity, and it is more targeted, and it offers personalized therapeutic benefits as compared to the older neurostimulation techniques such as ECT. So the first one is deep brain stimulation. So deep brain stimulation is a sophisticated neurological intervention, often described as pacemaker for the brain, a nickname it shares with the responsive neurostimulation, which is RNS. So it involves an invasive procedure. So there is implantation of electrodes by neurosurgeons into a specific region of the brain. So these regions will have already been mapped out by either a neurologist or a psychiatrist. So the neurosurgeon will implant the electrodes. I will explain how it is usually done. So how does deep brain stimulation work? So the DBS system consists of three key hardware components. So those are the electrodes that are implanted, which are leads. So these are thin wires surgically implanted by neurosurgeons into the brain targets that have already been identified either by a neurologist or a neurosurgeon, a neurologist or a psychiatrist. So these electrodes connect to extension wires. So the extension wires are subcutaneous wires that run from the brain through the scalp, under the skin to the chest area, and that is where the nickname neuropace or else neurological pacemaker comes in. So these extension wires will connect to a neurostimulator in the chest, and this neurostimulator in the chest is a pulse generator. It's a battery-powered device that will generate pulses that will stimulate the target areas in the brain. So the neurologist or the psychiatrist programs the device to deliver customized simulation parameters regulating abnormal brain signaling. So long-term efficacy in movement disorders has been established. So this DBS is primarily used to manage movement disorders. And these are neurological disorders. So it's neurologists who will be using it to manage the movement disorders, which will include essential tremors, Parkinson's disease, or dystonias. And these are advanced therapies. So the neurologist or the psychiatrist will first do testing, brain imaging testing, such as positron emission tomography or PET studies, or functional MRI studies to identify the problematic areas. And then these problematic areas will be where the simulation goes in. So in psychiatric disorders, it is being increasingly explored as a modality of treatment that is more targeted for refractory disorders in psychiatry. So that is resistant depression and OCD, obsessive compulsive disorder. So it is not yet explored for treatment of schizophrenia or bipolar disorder. So when treating obsessive compulsive disorders, they target the caudate nucleus and the orbitofrontal cortex for stimulation. And when treating treatment-resistant depression, they target the subcallosal cingulate area or Brodmann area 25 for stimulation. So the rationale being that when these areas are stimulated, the neurotransmitter activity is modulated and the symptoms of the disease are relieved. So they're also used in cognitive disorders, which the previous speaker talked about. So emerging research focuses in cognitive circuitry, such as when treating Alzheimer's disease, they target the phonics area, that is the hippocampal pathway. And the rationale here is to enhance memory formation and retrieval. And when treating tardive dyskinesia, which is a medication-induced movement disorder, or pseudoparkinsonism, also another type of medication induced movement disorder, being as side effects of antipsychotic use, then the target areas are the same as those organic movement disorders or the ones that occur without medication inducement. And the areas targeted are the globus pallidus internus or GPI. This is evidence-based to reduce symptoms in drug-induced hyperkinetic disorders. Also, the basal ganglia is targeted to disrupt the basal, to stimulate the basal ganglia circuitry. Other selected cases involve subthalamic nuclear stimulation and thalamus stimulation. As you all know, thalamus is the relay station of the brain. So when you stimulate that area, it covers a wide range of movement disorders. So summary of DBS targets are as follows. For movement disorders, it is GPI, subthalamic nucleus, and the thalamus, which are the target areas. And these ones will treat either primary or secondary movement disorders, being Parkinson's disease, tremors, dystonias, Tourette's, and what I mentioned as antipsychotic-induced movement disorders, which include tardive dyskinesia and pseudoparkinsonism. So for psychiatric use, caudate nucleus and area 25 are usually stimulated for treatment of OCD and treatment-resistant depression. So for treatment of cognitive disorders, which will include Alzheimer's disease, hippocampal area and the phonics are stimulated. And this one will treat Alzheimer's disease by improving memory retrieval. I already covered that. So the next modality is almost similar to deep brain stimulation, and that is responsive neurostimulation system. So RNS system is almost the same as DBS, but with one major difference. So the RNS system is not, the stimulations are not done by a neurologist or a psychiatrist. The stimulations are automated in the sense that the RNS system will read the brain's waveform and will try to identify an epileptic waveform before it happens and automatically trigger a stimulation that is going to cancel out those neuronal hyperstimulation caused by the and caused by the seizure area beginning to create an epileptic waveform. And in that case, it responds to it in time and it responds to it immediately. So the RNS system is a closed loop system of neurostimulation. The mechanism of action is unlike DBS, which provides continuous stimulation as programmed by the doctor. RNS is responsive to the brain's waveform. So it continuously monitors the electrical activities, detects it, and responds to it in real time. So the clinical outcomes are very good, with 75% median seizure reduction in a study that went for 9 years. That is as per Cleveland Clinic in 2019. So improvements in cognition and mental health occur either directly or indirectly. So indirectly is that when someone does not have seizures, number one, their cognitive health improves, because you all know that seizures will lead to cognitive impairment. And number two, when you don't have seizures, a lot of seizures in a day or in a month, then your quality of life improves. And in the biopsychosocial modeling of mental illness, when your quality of life is good, you are less likely to suffer stress-related mental illnesses. So this is how move to the slide which shows the electrodes placement. So the next one. So this is how the electrodes are placed in an RNS system. So electrodes, the tests will be done, such as positron emission tomography and functional MRI scans, to identify the problematic areas in terms of epileptiform, or else neurons that will generate an epileptic waveform. So the electrodes will be inserted to target those areas, and they will be wired to an RNS neuromodulator that is placed on top of the scalp. And that RNS neurostimulator will be reading the waveform of the brain, and when it notices a problematic waveform, it stimulates the area to treat the seizure. So next slide. So RNS systems will have various clinical benefits, like personalized simulation, because it reads your brainwave in real time, and it will have median seizure reduction of 75%. So it is highly effective, and it will improve cognitive and mental health, directly, I said, or indirectly. And another question that arises now is, if RNS is used to treat epileptic seizures, is it useful in treating non-epileptic seizures? So RNS is not useful in treating psychogenic non-epileptic seizures, which you also encounter a lot as psychiatrists. Why? Because the brain does not have, there is no electrical dysfunction in terms of how the brain's electrical activity is affected in psychogenic non-epileptic seizure. So there is no epileptiform signature in PNES. So that is why RNS cannot be used to treat PNES, because RNS responds to problematic epileptiform signature. So the next modality of treatment is called vagus nerve stimulation, or VNS. Now, VNS is an older type of neurostimulation, so it's not as new as the others, and it has two key different formulations in it. So there is the non-invasive one and the invasive one. So the traditional one is the invasive one, whereby a generator is implanted similar to deep brain stimulation directly into the vagus nerve, and a stimulator is placed on the chest, and the doctor will be stimulating the vagus nerve as per need. And the newer modality is the transcutaneous auricular VNS. So this one is non-invasive, and it uses or else it takes advantage of the fact that the vagus nerve has a sensory component to it that goes to the ear, the pinna of the ear. So those are two regions. That is the tragus and the cymba conchae. So I've already put an image there to show where those areas are. So there is a sensory component of the vagus nerve that goes here. So the stimulator will go there and stimulate it from the surface. So there is no implantation. So this one is non-invasive. So in medical applications, vagus nerve stimulations will be used to treat epilepsy, not as effective as RNS. So with 50% average seizure reduction as compared to 75% previous in RNS. So it also treats pain disorders like migraine and chronic headaches. It also modulates the gastrointestinal function through the gut-brain axis, as the previous presenters talked about, and also modulates inflammation and motility in the gut. As you all know, when you have stress, you get overproduction of gastric acid. So as we all, so because of that, we know that brain health is largely connected to gut health, and that once you modulate the gut-brain axis, then you'll be able to achieve better brain health. And we all know that the vagus nerve is one of the biggest cranial. It's actually the biggest cranial nerve and goes all over the body, including to the gut. So there is also stress regulation, as I've said. The vagus nerve is involved in with stress modulation, and this one is done through HPA. When you stimulate the vagus nerve, you also modulate the HPA axis. So finally, and this on vagus nerve stimulation in psychiatry, it can be used to treat treatment-resistant depression. It can be used to modulate neurotransmitters such as serotonin, norepinephrine, and GABA. It can be used to modulate HPA axis, which I've already talked about. It can be used for brain-body integration, like the brain-gut integration. And also, it recalibrates the fight or flight response to rest and digest. So meaning, it recalibrates the autonomic nervous system from preference of parasympathetic nervous system to preference of sympathetic, that is fight or flight, to parasympathetic, which is rest and digest. So to conclude my presentation, DBS, RNS, and VNS are approaches to neuromodulation that can be used in a better targeted way to treat conditions that we use ECT to treat. So DBS is a circuit level modulation, and it is a continuous stimulation, and it's a psychiatrist or the neurologist who does the stimulation to the targeted areas. RNS is a closed loop seizure detection and interruption. So the doctor is no longer involved after placing it. So the system works automatically. VNS is a broad neurostimulatory modality that utilizes autonomic nervous system innervation through the vagus nerve to modulate various biological causes of mental illness. And then the advantage over ECT is that it is more targeted and more personalized. Thank you. I have my references there. Thank you very much. Yeah.
Thank you so much, Dr. Katwa. So now I'll welcome our panelists, Dr. Arshni, Dr. Simon Kariuki, Dr. Katwa, and Dr. Kemunto. Kindly come forward. I'll be receiving your questions. couple of questions on neurostimulation, VNS. Are there cases of successfully treating post traumatic stress disorder with VNS?
Yes, I think because VNS mostly modulates stress reaction through the modulation, it modulates the hypothalamus pituitary axis to reduce stress reaction. And I said it switches response to stress from that of sympathetic response to that of parasympathetic response. So from fight or flight, which is stress, to rest and digest, which is parasympathetic, which is a relaxed and less stressful state. Then I think it can be successfully used for PTSD and other stress disorders as described in the textbooks.
Thank you. When it comes to DBS, how successful is DBS in treatment of Alzheimer's?
So DBS can be used to treat Alzheimer's through stimulation of the hippocampus, the hippocampal phonics. So as the presentation said, there is memory formation, memory processing, and memory storage. So when you stimulate that area, it helps the brain perform those functions better. So it can be used to relieve the symptoms of Alzheimer's disease in that sense, or other causes of dementia. As the previous presenter said, Alzheimer's disease might be the biggest cause of dementia, but it's not the only cause. Also, at the same time, we also borrowing from his presentation, we have to note that Alzheimer's disease is a progressive disease and cannot be reversed. So even those stimulations, those neural stimulations performed by DBS will only help to relieve symptoms and to slow disease progression, but it will not reverse the disease.
Okay. There's another question on neuroimaging and a bit of socioeconomics. Are there PETs and SPECT scans for psychiatry covered by SHA?
I believe people who work in big hospitals like Aga Khan and Chiromo can answer that question.
Do we have anyone with an answer? Actually,
I can't say it covers, but I think we have a PET scan in Aga Khan, and I believe there is a contributory part. It covers a very low percent. So most of the people have to actually pay, and I think it's about 70,000 based on one of my clients who actually did. I'm not sure if it's a current price, but it's definitely very expensive. Neuroimaging, the cost impact is what is the prohibitive part. Even when you have patients and you want them to go to a functional MRI, which they can get in general accident house, majority of them will not come back with it because they can't afford. So you end up managing patients based on their symptoms, but sometimes even if you know what to investigate, that affordability part becomes a limitation.
okay. So those in government, I hope you hear the cry. Thank you.
The question that was written to me is, how cost effective is DBS and where can we get it locally? So on the first question, it is not cost effective, so it is expensive, considering when I was in Brown University or affiliated hospitals, DBS used to be done as a procedure there, and it needs a multidisciplinary approach, which includes either a neurologist or a psychiatrist, as well as a neurosurgeon. And it is a neurosurgical procedure whereby they have to insert those electrodes to your brain. And also the equipment itself is expensive to buy. So the cost usually went in excess of $10,000, which is in excess of 1.3 million shillings, Kenya shillings. So I don't think it is cost effective. So on whether it is available locally, I can't say for sure that it is not available locally, but I doubt if it is available. Because after all, some of the hospitals that are coming that are innovative, like Chiromo Group hospitals, it could be innovative enough to have it. So I'm not sure about it. Maybe the people in this hospital can tell us. But recently, I saw SHA was offering sponsorship of treatment to countries abroad for procedures that are not available locally. But I did not see this procedure being listed there. So I think that is one thing that SHA can take up and sponsor people to be treated. abroad for procedure as one of the procedures that is not available locally. So another thing is that it needs development in terms of expertise. As I told you that a surgical procedure has to be done, so there has to be somebody to do the procedure. Also, equipments are needed, like the PET scans and the fMRI scans, and the people will interpret it and suggest which areas of the brain to be targeted. So you also need capacity development and equipment development also. And finally, I would say that the lowest hanging fruit among these treatment options is the VNS option. Number one, because it is older, so meaning there has been a lot of time to improve it and also to make it cheaper. And then number two, there is an non-invasive form of it that targets a sensory area in the ear, as I described during my presentation. So that is one of the neurostimulation stimulations that can be easily available locally to assist ECT, because ECT is doing the heavy weight lifting in our country. Thank you.
Thank you. I'm told we do have DBS and VNS locally available at Nairobi Neurocare Hospital. Dr. Horn has been part of multidisciplinary management of patients alongside a neurosurgeon who is doing very well. Okay.
So that means that is why SHA did not empanel it. So anyway, somebody's asking what is the cost.
I'm the one who was asking the cost, and I had another question before I answer what I've been given. We seem to be talking a lot about deep brain stimulation, vagus nerve stimulation, but nobody's talking about RTMS, and I'm wondering where was it left in terms of precision care, and how does it compare to the ones that you actually talked about, given that it's non-invasive, and actually we still have functional MRIs that can actually offer targeted stimulation to the brain activity, to the area where brain activity is not there.
Okay, so during the training, it was not covered, and that is why, because I was covering what we were taught when I went to that training. But as I was doing the presentation, I actually shared my presentation with another psychiatrist in Eldoret, where I work, and around that area. And she asked me the same question, and I replied the same answer that I've given to you. But now, in future, probably, I hope if I get another opportunity like this, maybe I can cover it.
I'm actually asking that question because there was a time Dr. Jengahan mentioned that he was going to bring the machine here, and we're very excited because definitely ECT, as much as it has been the old and old-fashioned, has been very beneficial, but it has its own risk exposures. And RTMS has even the portable form, and especially when we're doing maintenance for patients with chronic schizophrenia and those poorly responding to treatment. And it could have been something that bridges that gap. And in terms of portability, meaning that a patient can actually administer for themselves at home. The other aspect is, as I can hear my colleague talking about deep brain stimulation, by the time I convince my patient to actually agree to be open the brain and somebody places rods, if just taking medication is an issue, that will be something that we may not achieve sooner. And if I tell them that something else will be there that is just placed on the head, few minutes, and they're okay, they may buy into that. So we need to actually bridge that gap by bringing what is easily digested by the person we are going to be treating, while we are looking at the new precision modalities that may need longer training for that. And thank you. My patient actually benefited from it in India, and he's actually going back for another course. And there's been a lot of progress in his treatment for depression, which is treatment resistant.
Thank you very much for organizing this second symposium. And I do appreciate also the speakers who have been able to share with us the work they're doing, the work that is challenging the narrative that we're doing. When I was sitting there and Dr. Simon was talking about dementia, and then there was Dr. Katwa talking about the future, and that now we may need to put away ECT. I was like, I just launched the National Clinical Guidelines 2 years ago now. This dude want me to go and start reviewing them. You know, I'm not, in my head, I'm thinking, yeah, it's good progress. But now we also need to keep updating the policy documents that we have in place. And we accept that challenge because we are here as policymakers to guide and ensure that we give the best evidence-based interventions for our Kenyans.